we are going to talk about the total lab automation. So I'll just hand it over and then I will introduce the second speaker.
Thank you so much. Assalamu alaikum. Assalamu alaikum. So, my name is Ahmed Al-Barbari and I'm business manager for Middle East and Africa for clinical chemistry and specialty testing, including plasma protein, immunolytes, and allergy testing and drug of abuse. So, if I moved here, can you hear me well? Okay. Okay, that's perfect. Thank you. Now it's okay? So I will start. Is it working? So I would like to thank you so much for your time today. I will try to be quick. I know you're quite busy. We will cover during my presentation the plasma protein specialty part. So I would like to start my presentation with a question: why nephrometry is a method of choice for plasma protein testing? So any idea why nephrometry could be, or it's even by the guidelines mentioned as the reference method for plasma protein testing? Okay, so I will answer this question so briefly, and I will talk about each one of this in details. Nephrometry is giving better sensitivity and specificity. Nephrometry is giving or providing the customers with very wide assay measuring range, or we call it initial assay measuring range. Nephrometry or Siemens nephrometry is providing also very broad assay menu with more than 70 assays. We are also providing with our PN or Atelic NF system excellent operational performance. And there is unique solution that we can add also to our solution, which is called Protus software. So Protus software is kind of decision support software, and also we'll give an example of how we can use Protus decision support software. So to answer the first question, which is why nephrometry is the method of choice and why it is giving or providing excellent sensitivity and specificity, we need to see the difference between turbidimetry and nephrometry. So there are two methods in the market for plasma protein testing. The first one is the turbidimetry. The second one is the nephrometry. The difference between both of them, as in both of them, there is reaction happening between antigen and antibody. And at the end, we have the antigen-antibody complex. Then by light, this complex is scattering the light. Then in turbidimetry, we don't measure the scattered light. We measure the transmitted light. So we exclude the scattered light and we measure the transmitted light. While in nephrometry, after this reaction happens and the laser beam or the light beam, we measure the scattered light. So if there is any small reaction, it will cause scattering of the light, and this is what we measure. That's why it's one of the reasons why we are giving excellent sensitivity and specificity. The second reason why Siemens nephrometry is providing excellent sensitivity again is most of our assays called in-lattice. So in-lattice means we don't rely on a single antibody-antigen reaction. We rely on hooking or binding the antibody to a lattice. Then this lattice will magnify the reaction. So if there is a small portion of the antigen, which is improving the sensitivity at the lower end, we have this big reaction or big particle, which is causing scattering of the light. And in this case, also we can measure very low concentration of the antigen reaction in the sample. The third reason why, who knows about the Hooke effect? Hooke effect, any idea of the Hooke effect? Exactly, thank you so much. So when the concentration or the ideal reaction is happening when there is antigen or a small antigen concentration, which is giving low result, and there is optimal when the antigen concentration is equivalent to the antibody concentration, it's giving high result. But there is a very, very risky case where the antigen is excess or very high or too much, which is giving or interrupting the reaction and giving falsely low results for the sample. And this is risky because you may report the results with low concentration or with normal result, while the patient or the sample has very high or too much antigen, and this is happening mainly in free light chains. It's repeated a lot in free light chains because of the high concentration and multiple. So what our system or how our system is treating such samples, there is automated antigen access security. When you activate this option, then the sample or the machine is taking a small portion of the sample to start the reaction with. And if the signal exceeds certain threshold, it means that there is antigen access in the sample. And if it is lower than certain threshold, it means the concentration is low or normal, then it will go to the regular or normal dilution. So when the antigen or the signal is high, the machine automatically will move to the higher dilution, which means it makes huge dilution of the sample because of the antigen access, which is giving you the first result or the first accurate result. Okay? And also for this reason, we are giving, for the reasons I've mentioned, we are giving huge or very wide initial assay measuring range. What does it mean for the lab to give you very wide assay measuring range? What does it mean? Why it is important to have initial assay measuring range as wide as possible? What is the impact of the results? So when we give this for a lab, it means we are saving. You don't need to repeat the sample multiple times to get the result. You don't need to dilute the sample at certain limits because the initial measuring range is very wide. And you don't need to waste a lot of agents to do such procedures, which means at the end, lower cost and faster turnaround time for the lab. And this is an example of the assay measuring range. So here we are giving in free light chains 60% better sensitivity for free light chains. As you can see here, in lambda, turbidimetry 1.3, lower N, lower assay measuring range, and lambda here on nephelometry is 0.48. And here, kappa 0.6, kappa here on nephelometry is 0.17. So you can see the big difference in the assay measuring range. And here in IgG subclasses, we are giving also 55 better sensitivity on the IgG. Okay, so, and that's why, because of this reason again, the nephelometry is mentioned in the International Myeloma Working Group guidelines and ISMO guidelines as a method of choice for multiple myeloma diagnosis. So, again, as I mentioned, we are providing more than 70 assays on our benchtop Atelic NF system, which includes unique assays that you will find only on Atelic NF system, and also very high performing assays as we have mentioned. And we have this very extensive assay menu that covered a lot of disease states. As you can see here, the gammopathies are covered. Yeah, so coming back to the assay menu, do you have any questions on the assay menu? Everything is clear? So I will just focus on few assays just for the sake of time. So as you know, the chronic kidney diseases is increasing, and in many studies they call it the silent threat because of the symptoms that doesn't show any pain for the patient, and at the same time it is very dangerous, and if we left it, it develops with time, and it causes a lot of problems. And as you can see here, according to the studies, that 1 in each 10 persons could have some kind of chronic kidney diseases. So, and it causes around 850 death cases every year, and around 1 billion is under risk. So chronic kidney diseases is one of the most important diseases that needs focus. And as you can see here, it costs the countries or the governments a lot. So in Australia, they found that it costs them, the chronic kidney diseases, annually $12 billion US dollar. And in China, they expect the cost or the investment on the chronic kidney diseases to be 558 In Uruguay, 23 billion, and in US, it's more than 30 billion. So this is really a significant investment on the chronic kidney diseases. That's why there is really focus on the right assays and the right method to assess the chronic kidney diseases. So some studies here rely only on the cystatin C, some others rely on the creatinine, and some other studies rely on the creatinine and cystatin C to get the GFR. So the problem of relying on creatinine, according to this study, that they found that there is something called creatinine blind range, where the creatinine could be normal while the cystatin C or beta-trace protein calculated GFR is giving high results. And in this case, creatinine is not a good tool to assess the chronic kidney disease, especially in the early stage. So they found that, and again, according to this study, that called meta-analysis and combines around 16 studies that was done on 90,000 patients, and they concluded the study that cystatin C alone or in combination turned out to be more powerful indicator for chronic kidney diseases. So relying on creatinine only might not help a lot in some cases, but relying on cystatin C alone or in combination with creatinine is more powerful indicator of chronic kidney diseases. The second indicator is the beta-trace protein, and this has two applications. The first one is, as you know, suspicious of CSF leakage. So do you have trauma and you check the beta-trace protein in your lab, in any lab you are doing it? Beta-trace protein. So beta-trace protein used to be indicator of CSF leakage. In case of trauma, if somebody was hit hardly in his head, or in case of accident, and there is leakage coming from his nose, then this could be an indicator of CSF leakage in his nose. So they get this sample and they test it. The traditional way is, either checking the MRI or to run the beta-trace protein or beta-2 transferrin using electrophoresis method. While we are introducing beta-trace protein as one of the unique assays on a telecannef system, and it is 12-minute results. So you run the sample, you get the result in 12 minutes to assess if there is CSF leakage or not. The second application is in the dialysis patient. They need to run dialysis or to do dialysis every while, like maybe on a weekly basis or monthly basis or whatever the situation. So that's why they rely on now on the residual renal function to assess the native membrane of the kidney. Because usually if the residual renal function is less than 10, then the patient needs to go to dialysis. If it is more than 10, then the patient is fine and he can wait. Dialysis is not an urgent. So they relied on collecting 24-hour or 48 hours urine sample to do the residual renal function. And this is a very hard process, or very hard procedures, which can be impacted by a lot of factors that can affect the quality or the accuracy of the results. Beta-trace protein now this is the future assay that can be used to assess the residual renal function by taking only one serum sample. No need to collect 24 hours or 48 hours urine sample. You just need to have one serum sample and to do assessment for residual renal function. Why? Because they found that the beta-trace protein is not filtered through the hemodialysis membrane. So it is filtered only or cleaned from the blood only through the native kidney membrane, which means that if it is filtered up to a certain limit, the native kidney membrane is working fine. If not, then the patient will need dialysis. And that's why they rely on the beta-trace protein, as you can see in this graph here, that we can rely on the beta-trace protein up to 10. It will indicate the status or the performance of the native kidney membrane, even if the patient has kidney failure and he has to do dialysis every while, but this will give indication on when you need to do dialysis. When the patient or the physician needs to request dialysis, based on this one. Instead of making a lot of dialysis for the patient without knowing what is the status, you have this tool, and this also, they found it a useful tool to save the money that is spent on the dialysis that can be done blindly. The third one is the serum amyloid A. So serum amyloid A is one of the inflammatory indicators or markers that was widely used during COVID-19 because they found that it is responding more to the viral infection. So CRP is responding more to the bacterial infection. As you can see here, all of these are viral infection, and the response of CRP is very low or it doesn't respond at all. So when you check the CRP for viral infection, it may not be a good or more efficient indicator, while serum amyloid A is increasing significantly in the viral infection. And that's why a lot of studies has been released from China and different countries, and we have even one study from the Middle East, from Saudi Arabia, claiming how important measuring the serum amyloid A to assess the severity of COVID-19 patients. And they found that if the serum amyloid A is increasing steadily, it means the mortality rate could be high for the COVID-19 patients. Because in this case, it will increase up to 20 folds compared to CRP that can increase only 2 times. And that's why this means this is very severe infection of COVID-19. And in serum amyloid A, it doesn't say anything because it increases like not significantly like the serum amyloid A. So in latex free light chain that we introduced or we have introduced on nephrometry, which is using Siemens assay and also the Atelica Neph of Siemens. And when they have done the comparison between the assay in the market and the free light chain of Siemens, they found that there are some differences in some cases between both of them. Why? Because Siemens is using monoclonal antibody, and the other turbidimetry assay is using polyclonal antibody, and it is really affected by the renal impairment. So if the patient is performing dialysis, they found that the result is dropped to match with Siemens results, and when there is a need for the hemodialysis, it means there is a renal impairment, which is affecting the free light chain ratio and also giving false result or misdiagnosis for multiple myeloma. And to confirm that, this hospital in Netherlands, they have also checked with the reference method, which is the immunofixation. So they compare 3 methods to see which one is closer to immunofixation. And here they found that Siemens is performing the same exactly as the immunofixation method. So this is the difference between turbidimetry and nephrometry in some cases. In addition to that, as you know, the different stages of multiple myeloma starts with MGUS, or this monoclonal gammopathy of undetermined significance. And this is very early stage because 1% only of the patient is progressing to the next stage, which is a smoldering myeloma. So Siemens is the only assay, free light chain, that got FDA clearance for MGUS evaluation, which is the very early stage of the multiple myeloma. And in this case, and of course, because of what we have mentioned, the nephrometry and the in-latex and the technology that we are using. So at the end here, this free light chain is using nephrometry with higher sensitivity and specificity. It is giving you lot-to-lot consistency, so you don't need to do comparison when you get new lot number because we are using the same antibody pool to produce every new lot number. So we don't change the antibody pool, which means that you have lot-to-lot consistency and no need to do the comparison between the 2 lot numbers. We have the MGUS claim as well, as I mentioned, and you have the flexibility to order reagent, calibrator, or control whenever you need it. So another thing for MS, multiple sclerosis. So how multiple sclerosis is in Pakistan? You have a lot of cases, few cases. What is the status? A lot? Few? Yeah. So for MS, we have seen a lot of interest in many countries, and the guidelines in each country is different. And most of countries are relying on the oligoclonal ban, which is very subjective evaluation. It depends on the person who is looking at the results, and in some cases, it is misdiagnosed. So recently, we have introduced this free light chain kappa index using free light chain kappa in the CSF and also serum, albumin CSF and albumin serum to assess if there is multiple sclerosis or not. And usually this is more powerful because it's coming numerical results, and usually the threshold according to a lot of studies is 3.045. So up to which you can expect multiple sclerosis, and below which you can say the patient is normal. So TNF-alpha inhibitor assay, and as you know, the role of the lab in rheumatoid arthritis diagnosis using rheumatoid factor, CRP, ESL, and optional assays like C3, C4, and other assays. But there is another tool to assess the progression of the disease and how the patient is responding to the treatment. So in this case, we have introduced calprotectin in serum to see the severity of the disease and the disease activity, and TNF-alpha inhibitor assay, which is checking 3 different drugs, adalimumab, infliximab, and etanercept, and these are the most common drugs used for rheumatoid arthritis. Why this is important? Because they found that 10 to 30% of the patient are having primary resistance to the drug. So when the physician ordered or requested drug to the patient is not responding to the treatment, and in this case, it is symptoms becoming more severe. And they found also that in 20 to 40% of the patient, they develop secondary resistance to the treatment, to the drug. And also in this case, the physician is checking or assessing the status by see what's happening on the symptom side. While we have introduced this assay to see if the patient or the treatment is within the certain threshold according to the guidelines, which means the patient is responding to the treatment and there is no primary or secondary resistance, or in this case, that means the patient is developing secondary resistance after a while, immediately the physician has to take the decision to change the treatment or to increase the dose in order to maintain the therapeutic drug which is working for rheumatoid arthritis. And here we are introducing one reagent only with 3 different calibrators to measure the therapeutic drug range. The operational performance we are introducing, the system is providing you with automatic dilution, which can reach up to 1 to 160,000. And it's making serial dilution of the sample and no need to take the sample. I mean, if there is a need to repeat the sample or to rerun or to take another sample, it's using this segment or dilution segment, which is giving also quick turnaround time. And this is the system, benchtop analyzer, that And last thing, I know the time is short, I will go fast in this part, the decision support software that can introduce 4 different assessment kits, CSF, and it relies on ordering the profile. The machine will take the order through the LIS, and then the samples will run, then it will send the result to the process software. It will analyze the result and give you very nice report. As an example of the kidney profile, this is the report with the numerical data. So here is the patient demographic. This is the numerical data, including GFR, cystatin, and calculated data as well. And also comment what is expected as a disease and what is recommended by the software, and this graphical representative of this certain profile. With this, I would like to thank you so much, and sorry for longer time.
Good afternoon, everyone. My name is Antonio Buharoun. I'm healthcare consultant for Middle East and Africa. Today we will talk about the latest innovation in automation and IT that we have it in Siemens. So first, I would like to start with a short video that will show you how the automation can enable the workflow excellence inside the lab.
Aptio automation drives laboratory workflow efficiency based on possibilities, not limitations, to support your diagnostic testing mission. Open connectivity. With easy expansion of high-volume chemistry and immunoassay testing. Unrivaled connectivity, time-tested technology, and an unmatched track record of innovation. Each custom-designed Aptio configuration is designed by experienced workflow consultants using patented tools to accurately project and refine ongoing performance. Integrated and customizable, Atelica Diagnostics IT amplifies TLA performance. Expertly delivered. And supported by award-winning service teams. Total lab automation with Aptio automation is a journey of continual engineering, IT, and service innovations for ongoing improvements in lab performance.
So I will go to the second slide. Here we will keep it locally and we will talk about some success story here in Pakistan. So I will start with Dow University Hospital in Karachi. We got awarded for this site and the implementation. It was in 2020 and it was not easy because it was during COVID, and we had our state-of-art automation in this lab. Also, the length of the length of the track, it was 26 meters in this site, and we have a full integrated solution for the biochemistry department with IT. And now they are working on this automation, and they are running around 7,000 tests and around 20,000 tests per day and around 7,000 tubes. Also, I would like to speak a little bit about Shaukat Khanum Memorial Cancer Hospital. Also, we got awarded recently for this hospital, where we designed also our state-of-art automation from Siemens. And here also we had many challenges that we need to replace 3 different automation available on site, and we need to connect up to 6 different disciplines on the automation. So we have chemistry, immunoassay, and serology from Siemens, and we have hematology, coagulation, ESR from Sysmex. And now the automation will, the capacity for loading samples, it will be around 1,700 tubes per hour, with a throughput of the analyzer around 7,600 tests per hour, and with a capacity of storage around 30,000 tubes. So behind every success story, there is a lot of effort starting from the customer, our business partner, Hura, and as well as Siemens. And here's some picture from the signing contract of Shaukat Khanum Hospital. So I will talk about the portfolio of Siemens Healthineers, but I will skip these 2 slides due to the time. And I will talk about the portfolio of Siemens. So Siemens Healthineers delivered a wide portfolio for analyzers and solution, and it will start from the discipline level, as we can offer a solution, the Atelica Hema work cell, the Atelica solution, and as well the Atelica integrated automation. And if we need to go beyond the discipline and we need to automate the lab, so also Siemens has a solution. We have our new Atelica targeted automation. We will talk about it during the presentation. And also we have our strong TLA. We have the Aptio automation, and also we have the Flex Lab HT, that it's for the highest capacity lab. Now we will talk about automation. I guess everyone likes numbers, especially when it comes to statistics, but numbers cannot only convey you to know how much we are expert in the automation, but at least it will give you an idea why Siemens has kept gained the leading rank for total lab automation, because we are available for more than 20 years in automation, and we are available in more than 70 countries across the 5 continents, and we have more than 2,300 automation live globally. And we as HCS, we are doing yearly around 1,100 healthcare consultation, and we have more than 14,000 analyzers that they are connected to Siemens automation. Not all TLA or total lab automation, they are equal. There is difference. When we say about Siemens, that Siemens provide you a comprehensive end-to-end solution, it's from the time that you place the tube on the track till the dispose of the tube. So it's end-to-end solution, one touch, one flow. So from the moment that we load the samples on the analyzer, immediately all the pre-analytical tasks will be automated, like centrifugation, decapping, mixing. Everything will be done by our modules. Once the sample is ready, it will be routed based on test order to the analyzer. And here we can offer up to 50 instruments across 11 specialties that they can be connected to our track. Once the tube is done, it will move to the post-analytical phase, where it will be aliquoted, sealed, or even stored till the dispose of the tube. All these modules and analyzer connected to the track, they are the muscles of our automation. And everything is managed with the brain, our intelligent diagnostic IT. We have a full portfolio of diagnostic IT, ADM, APM, AIM, that they control the automation, and we consider them as the brain of our automation. Here I would like to introduce for you our new module that it was available only at the market for one provider, but now it's available for Siemens. It's the sample detected module that it will be placed on the track, and it's responsible to detect the sample volume and the serum indices with a throughput of 500 tubes per hour, and it's working on optical technology with the accuracy of 99%. And we can place an unlimited number of modules based on the workload and the activity. Also, we have something unique for Siemens, the on-track automated sample mixing. So we have the mixer that mixes the sample before testing and some special assays like HbA1c with a throughput also of 700 tubes per hour, and it can be placed also on the automation. And also when we talk about the third-party connectivity, we have the largest third-party connectivity for Siemens because our automation is open. We can connect Siemens and non-Siemens analyzer. We can connect molecular. We can connect urine analysis. We can connect electrophoresis, HbA1c, ESR. And also we have all the 4 main pillars from Siemens. We have chemistry, immunoassay, serology, hematology, coagulation, and we have unique the allergy and the plasma protein that they can be connected also to the track. Now we will shift to the new launch for fiscal year 2024. We are launching the Atelica target automation. Okay, so this will be available at the beginning of the year, and this is the TTA, that it's used as open multidisciplinary for automation. And here we will see a short video about the Atelica TTA and what is the role for the TTA. We know inside the lab there is a lot of pre-analytical steps, okay, once we receive the sample inside the lab. So the TTA will help us to automate this pre-analytical steps. Whenever the sample is loaded to the TTA, it's immediately have the sample check-in, sample quality check, centrifugation, decapping, aliquoting, recapping, and the most important is the pre-sorting of the sample on specific racks. So here, all what is needed from the end user is to take this rack, specific racks, and load it to the analyzer. Okay, so it's open to accommodate other analyzers that are available inside the lab. And this is not all. Also, it can help you in the post-analytic phase, as it can post-sorting, archiving, and also sample tracking. So with the TTA, we are automating up to 12 pre- and post-analytical tasks inside the lab. Now let's check what are the configuration that you can have it inside the lab. Also, the TTA is flexible, so we can go from a small analyzer, add our higher throughput module, the HTM, on the left side of the TTA, and here we get an additional arm inside the TTA, and the throughput will go to 1000 tube per hour. And now I have 8 drawers, 2 they are dedicated for input and 6 for output. And the capacity is 1536 tube. And also if the lab needs to automate the centrifugation, also we can add a centrifugation on the left side of the ATM. And with the centrifugation, with a throughput of 300 tube per hour and the capacity of 240 tube. So as we said, it's scalable, and we can add with time based on the activity of the lab and maybe based on the workflow if needed. As we know that the main task of the TTA is the sample sorting. So most commonly used analyzer rack are supported by TTA. Now we have more than 30 rack type from different analyzers that they are supported by the TTA, and the list is growing as well. And also we have the SBS standard 96 well microplate that can be used also on the TTA, and it's used for biobanking or infectious disease testing, and really it's reduced time for the technician to do the manual pipetting for this microplate. Now I will shift to the diagnostic IT, and also during the 20 years, Siemens also has improved the diagnostic IT portfolio. We have our ADM, we have our APM, Atelica Process Manager, and we have our Atelica Inventory Manager. And also, we have our quality management tool, the LEAP, that will help you to be ready for any type of accreditation. And also, we have the sample tracking and management system, and we have the artificial intelligence-based clinical support. So first, the Atelica Process Management, it's It will help you to improve the workforce productivity inside the lab, and it's mainly used by the supervisor and the lab director because it has a lot of built-in report based on business intelligence that will help you to take immediate action, and it's based on real time. As you can see here, we have a lot of reports that they are built in, and you can create any report because we know that KPIs they are very important for the lab, and you can create any report and it's real time, and at any time you can take immediate action for the task that you are looking for, like problem solving, reagent efficiency, turnaround time, auto validation. So you have a lot of built-in report. The ADM, it's our next generation middleware software. So it's used by the technician, and it has a lot of features. It simplifies the lab operation, so you can have this screen inside the lab and you can know everything happening in the lab. It's efficient result management, and especially with the auto validation. Also, it simplifies QC management. It has advanced workflow. It can go from simple to very complex rules, like reflex test, repeat, dilution, or even calculated parameter. And we have our Atelica inventory management system that it will give you an automated inventory management, and it's a cloud-based system that can be run on the mobile or even on the website. And also it's touch-free RFID, and it has multiple locations, and it can be used for Siemens and non-Siemens. And also when we talk about the solution, we have the Sample 360 software that is used for the hospital that they have primary health collection center, and they are collecting samples from outside. So this is a tracking system. So you will have report and dashboard for audit trail trends analysis and GPS tracking for these samples from the collection to the receiving for the lab. And here we have some data for this system that they are implemented in a KSA, and here we connected around 67 primary health clinic to the lab. Okay, so I will stop here for the presentation, and I will skip the last two slides because they told me that we ran out of time. Okay, so if you have any question, we are here.